you hear me?
Hear you.
Hello.
Hi.
Hey, so we can see you right now. So
Okay.
I'm going to introduce you. Hello, everyone. Thank you, everyone, for being part of this amazing course sponsored by the Egyptian Society of Radiology and Nuclear Medicine and the Radiology Department, Bena University. Today is our 24th session, and we have a unique speaker from Northwestern University. Dr. Rishi Agrawal is an assistant professor of radiology at the cardiothoracic section at the Radiology Department, Northwestern University. He's interested in radiology education, and he's a founder of Thoracic Radiology channel on YouTube. He's going to give a talk today about TNM staging of lung cancer. I hope everyone enjoys this lecture. Dr. Agrawal, thank you for being a part of our course, and we would love to hear you today. Thank you.
Thanks so much. If I could just have you go on your phones or open up a new browser window so that we can be a little bit participatory. I have some questions that I'd like to ask you. If you go to pollev.com/Rishi, and the first question is, what country are you from? And hopefully you'll be able to see that question come up, and I hope this works.
So but it's can we use the phone or just the browser and computer?
You can use your phone.
Okay, so let me ask people, can you guys please type in chat if you can hear the screen, if you can see the screen? Okay, so everyone, please, can you open this website on your computer or your browser on the phone, please? Okay, so welcome to Rishi presentation. Introduce yourself, enter your screen name. You would like to appear. This one?
Yeah.
Okay, cool.
Okay, it looks like we're getting a lot of, there may be, okay, so it's mostly Egypt, huh? That's great. The other thing that I would like to ask for some of you to do, not everybody, but one of the things that we oftentimes miss out on when we're talking to a group that is not in person is whether or not the people in the audience understand what I'm saying. So, and I try to rely on people's expression on their faces to do that. So if I could just have maybe 15 people or so turn on their cameras, that would be super helpful for me, so I can tell whether or not I'm making sense, or whether I need to go over something again. If you could, please. Okay, and I'm going to go on to my next question here, which is, are you male or female? So in the United States, I looked at the data from a couple years ago, and 75% of radiologists in the United States are, at least radiology trainees, are male. And I just wonder whether that's the same elsewhere. Looks like, wow, 69% are female, it looks like.
Yes, female radiologists are more than male in Egypt.
Wow, that's great. Here we have the opposite issue. We have like 75% male, 25% female. And then last question here is, what is your favorite hobby? I'm not sure if, let's see if you could see this. Okay, we have some people who like chess, fishing, interesting. Stamp collecting, reading, cooking. All right. Cool. All right, well, great. So this looks like it's working. I'm gonna go ahead and continue here. I have about 10 questions throughout this course, and we're gonna play a little game to go over some of these topics. But Yeah, I'm going to talk about lung cancer staging, specifically the 8th edition of TNM lung cancer staging. And since we're talking about TN and M, I'm going to talk about each one of those things specifically, and then we're going to put it all together. But just to start out, preoperative CT is considered which of the following? Let's see. Preoperative PET CT is considered which of the following? Okay, another question for you. How about this one? Percutaneous, okay, let's see. Most people said retreatment staging. The correct answer is clinical staging. Okay, the correct answer is clinical staging. We'll go over that in a second. Okay, good job. Looks like 5 people got it right. Let's go to the next question. Percutaneous biopsy is considered which of the following? Clinical staging, pathologic staging, autopsy staging, or retreatment staging? A percutaneous biopsy prior to surgery. Okay, 5% of people got this one right. Most people said pathologic staging, but the correct answer is actually clinical staging, and we'll talk about that in a second. Okay, so let's go over the overview of staging first, okay? So what is staging? It's something that we do to categorize the extent of a disease, okay? And the most obvious example of that is in cancer when we talk about cancer staging, but it can also be for organ failure like heart failure or kidney failure. It can also be for things like sarcoid or cognitive diseases like Alzheimer's disease. And the purposes of staging are many, but one of the obvious purposes is that if you want to communicate with a colleague, then it's easier to say that a patient has stage 4B lung cancer rather than saying the patient has a right lung cancer with metastatic disease to the liver, the brain, and et cetera, et cetera. So it's a shorthand way to communicate the disease extent. And it's also used to guide treatment. So it doesn't tell you everything you need to know about treatment, but it often is the first step and often is the step that'll tell you whether or not the patient can receive surgery. And there's other things that obviously go into that determination, like the patient's performance status and the genetics, but the stage is usually the first step in the guidance for treatment. And then the third is it's used to estimate the prognosis of the disease. So these are survival curves showing the survival of patients with lung cancer based on the stage. And you can see for each increase in the stage, the survival decreases. And there's very little overlap between these lines. So it means that an increase in the stage has a real world implication, which is survival. And then fourth is that it aids in research. So when you're doing research, what you have to do is first define the patient population. And if everybody is using a different standard, then it really is difficult to do research. So that's why if we can agree on universal definitions of stage, then research can be done more fluidly. So this question about clinical versus pathologic staging. As a radiologist, we deal mostly with clinical staging rather than pathologic staging. But clinical staging includes a lot of things: the history, the physical, the lab studies, the imaging, and the biopsies. So if a patient has a percutaneous biopsy of a tumor, that's considered still part of the clinical stage of the disease. Now, if that patient goes on to have resection of the primary tumor, then the clinical stage information is added to the information that is obtained during primary resection of the tumor, and that is called pathologic staging. Okay, and so patients who sometimes aren't, if a patient isn't eligible for having surgery for their cancer, then that patient is only going to have clinical staging. They won't have pathologic staging. Pathologic staging includes primary tumor resection. Okay, the clinical stage and the pathologic stage can differ quite a bit. 60% of the time when we have an enlarged lymph node on CT, those lymph nodes are positive on pathology, but that means 40% of the time those lymph nodes are negative. And on PET CT, even on PET CT, if a lymph node is hot, then about 15 to 20% of the time, that lymph node is still going to be negative on pathology. Okay, so clinical staging can differ significantly from pathologic staging. And the way this is notated, by the way, is right before it says T3N2, you'll see a little P or a little C right next to it. So it'll say C, T3N2M, whatever. That means it's clinically staged. Or if it says P, that means it's pathologically staged in the notes or in the literature. Now, there's other kinds of staging, but they're not as common. So post-therapy staging is done after the initial treatment to measure the response. Autopsy staging is done after post-mortem analysis, and then retreatment staging occurs after a disease-free interval. Okay, so specifically for staging for lung cancer, we're on the 8th edition of TNM staging, and it started in 2018. The 8th edition came about in 2017, and it was initiated in January of 2018. And we're already in 2022. So I suspect that if some of you are first or second year residents, by the time that you become an attending, we're probably going to already be in TNM 9 for lung cancer. Okay, so the histologic types include all of these, but primarily it's for non-small cell lung cancer, but it can be used for carcinoid, it can be used for small cell as well. And this data came from 77,000 patients with lung cancer all across the world. Okay, some more questions. A 3-centimeter tumor directly invades a rib. Which category does this affect? So if you have a tumor that directly invades the rib, does that affect T, N, or M? Okay. Okay, most people said T, and that's right. This affects the T category. How about this question? What is the proper way to measure a tumor for TNM staging? Measure the single longest axis, take the average of the long axis and orthogonal dimension, or take the average of all 3 dimensions. Okay, let's see what people said. Okay, most people said take the average of all 3 dimensions, which is not correct. The actual correct answer is measure the single longest axis. Okay, so let's keep going. Let's talk about the T category. There's 2 components of the T category, the size and location. Okay, so the T category is a lot easier to understand in the 8th edition compared to the 7th edition. In the 8th edition, every centimeter increase in the T category in the size of the tumor increases the T category up to 5 centimeters. And then from 5 to 7, it's a T3, and then above 7, it's T4. Back in the 7th edition, it was very confusing. First, it was T1A is up to 2, then there's 1 centimeter increase, then there's another 2 centimeter increase. But now it's much easier to understand. So every increase in size from 1 to 5 gets a separate T category. And then the way I drew these is that 3.0 over here is a T1C, but 3.1 is a T2A. Okay, so over here, a 5.0 is T2B, but 5.1 would be a T3. Okay, and then above 7, so 7.1 and above would be a T4. All right. So the way we measure the tumor is we take the single longest axis, and this is different from the way we do it in lung cancer screening. So for lung RADs, for lung cancer screening, we take the longest axis and then we take the orthogonal axis to that and average them. The way we do it in TNM is just take the single longest axis. And that means that we have to use all the views. So even though we mostly use the axial views for our diagnostic work, if the longest axis is in the sagittal or the coronal plane, we'll use those for the TNM. Okay, so in this example, the longest axis in the axial plane was 1.8 centimeters. But if we went to the sagittal series, then the longest axis is 2.3. So it went from a T1B to a T1C. And then the other thing is you have to use the lung reconstructions. If you use the soft tissue reconstructions, then you can potentially be underestimating the size of the tumor. So in this example, you could see that the spiculated margins are much easier to see when we go to the lung windows. When we go to the soft tissue windows, it underestimates the size. Okay, so be sure to use the lung recons and the lung windows. And then finally, you want to measure the solid component. Okay, so if a lesion is subsolid, meaning that it's ground glass plus solid, the T category is based on the solid component. And usually in my report, I'll measure both the longest axis, including the ground glass, and the solid component both. But you should know that it's only the solid component that goes for the T category. And the reason why this is important is because we know that pathologically, the solid component is what is the invasive component when we have our pathology correlation. So in this example here, it's a sagittal image showing a 1.4 centimeter tumor abutting the major fissure. So this would be a T1B if we measured the whole lesion. But because we're only measuring the solid component, it's actually 8 millimeters. So that would make it a T1A. The other reason why that's important is because if you only measure the long axis of the lesion, you could be missing out on actual growth of the lesion. Because we know that the solid component correlates with the invasive part of the tumor on pathology, we know that that part is going to grow faster than the ground glass part. Okay, so in this example, on baseline, the whole lesion was 14 millimeters. And then on 6-month follow-up, it was still 14 millimeters. So if you were reading this and just measured the long axis, you would say there's no change here. But if you looked at the soft tissue windows and you looked at the, not the soft tissue windows, but if you looked at the solid component, you would see there's actually substantial growth of the solid component here from 5 millimeters to 8 millimeters. And that might spur you to take this lesion out. Okay, so these are, so that's the size. The other part of the T category is location. Okay, and these are all the things that if the tumor invades, it bumps it up a category. Okay, and if it invades a structure, it can't bump it down. So in other words, if I have a 7 centimeter tumor, but it invades the main bronchus, it doesn't go down to T2, it stays at T4. Okay, the location can only upgrade the tumor, not downgrade the tumor. So let's take a look at these. T1 is basically a nodule that's surrounded by lung or visceral pleura. without evidence of invasion of a main bronchus. So here's a 1 centimeter tumor that's sitting out in the middle of the lung, and it's not really touching anything. This would be a T1 lesion. Now, if a lesion simply touches the pleura, then I can't say whether or not there's invasion of the pleura. That's something that the pathologist has to determine if it simply touches the pleura. There are a couple of radiologic signs that will tell us whether or not the nodule actually invades the pleura, which I'll show you in just a second. Okay, so this is a 1.8 centimeter, 18 millimeter lesion, and it touches the pleura. And so this would be a T1B. T2 is a tumor that causes atelectasis or pneumonitis of part or all of a lobe or part or all of the lung, okay? It also becomes T2 if it invades the main bronchus or the visceral pleura, okay? So in this example, this lesion abuts the pleura, but I can't say whether or not it invades the pleura. But by size criteria, this is a T2 because it's greater than 3 centimeters. Now look at this case. So this case, the nodule is only 2.8 centimeters, but it touches the pleura, right? So if I looked at this, I can't say whether or not it invades the pleura. Now, on the sagittal images, if I zoom in, what you can see is that on the other side of the major fissure, there is a little bit of spiculation or lobulation on this side. So if I see that, that is a very good sign that it actually crosses the visceral pleura into the left lower lobe in this case. So if I see that, that is a sign that this is a T2 lesion. In other words, it invades the visceral pleura, okay? If this were a smooth border, even if it's pushing the fissure, that is not enough evidence for me. It has to be spiculated or lobulated on the other side of the fissure for me to say there's visceral pleural invasion, okay? Another criteria, I mentioned, is post-obstructive atelectasis. So this can be part of a lobe or the whole lobe. So in this case, we have a 2.6 centimeter lesion, which would be a T1C. However, you can see that there's atelectasis in the anterior segment of the right upper lobe here. So that would push it up to a T2. Now, a T3 is an even larger lesion, so 5 to 7 centimeters, with a separate nodule in the same lobe or invasion of the parietal pleura, chest wall, phrenic nerve, or parietal pericardium. Okay, so in this example, this is a 5.4 centimeter lesion, and it's not invading anything. So this is a T3 lesion just by size criteria. Now, in this case, here's the primary tumor, and it's 4.7 centimeters, which would make it a T2, a T2B specifically. But if you scroll down, you could see that there is another nodule in the same lobe, in the right upper lobe. So that bumps this lesion up to a T3, okay? For the 8th edition of TNM, it talks about lung cancers with multiple lesions. And for the example I just showed you, that was an intrapulmonary metastasis, meaning that the smaller nodule has the same histopathology as the bigger nodule. Now, there are some cases where you have another nodule in the same lung or a different lung, but when you take the histopathology, it's a different tumor. For example, it's a squamous cell versus an adenocarcinoma. That would be an additional primary tumor, and it's treated differently in TNM staging. There's also 2 other categories, multifocal ground glass adenocarcinoma and diffuse pneumonic type adenocarcinoma. And you should know that these have their own specific rules for TNM staging, which I'm not going to go into in depth here. But for the purposes of the T category, an intrapulmonary metastasis in the same lobe would be T3. Okay, now here's an example of chest wall invasion. So remember in the case I showed you earlier, the lesion was simply touching the pleura. And in this case, we have a 4.7 centimeter mass. So it's a T2, but on the soft tissue windows, you can see that the soft tissue goes all the way up to the bone and it goes to the intercostal space here. So if I see that, that is a very good indication that there's chest wall invasion. And compare that to the case I showed you before where the lesion just touches the pleura. In this case, there's a very thin layer of fat in between the mass and the intercostal muscles and bone. So here, I would have to leave this up. This may invade the pleura, but I can't say that radiologically. I would have to leave that for the pathologist to say. This one, I can say it invades the chest wall because the soft tissue goes all the way to the bone, okay? So that's chest wall invasion, making it a T3. Phrenic nerve invasion, remember that the phrenic nerve runs along the lateral border of the mediastinum, along the pleura. So if you have a patient who on chest x-ray has an elevated diaphragm, that's a good indication that there's phrenic nerve invasion. So this tumor, even though it's only 4.4 centimeters, because there's phrenic nerve invasion, makes it a T3. Okay? So T4 are large tumors, 7 centimeters or greater, and or they have a separate nodule in a different lobe of the same lung, okay? Or it invades the mediastinum, the diaphragm, or the spine. So this lesion here is a 10 centimeter lesion, so that makes it a T4 by size criteria. In this case, we have a smaller lesion, 4.1 centimeters. That actually makes it a T2, but unfortunately, this person has a nodule in the right lower lobe. So it's an ipsilateral nodule in a different lobe that makes it a T4. And this patient has mediastinal invasion. So we have a relatively smaller tumor, 5.8 centimeters, making it a T3. Unfortunately, though, there's in direct invasion of the mediastinum, we see soft tissue in the fat of the mediastinum here. Okay, so that's mediastinal invasion. A Pancoast tumor. So this is a Pancoast tumor. This is already T4 by the size criteria. But Pancoast tumors, if they just invade the ribs and the chest wall, it's a T3. But if it invades the spine or let's say the subclavian artery, then it's a T4 because that would be mediastinal or spinal invasion, okay? All right, so there's other special categories of the T category. TX is when the primary tumor can't be assessed. And this can happen when a patient, let's say, has sputum or washings in which you see tumor, but it's not visualized on imaging or bronchoscopy, okay? A T0 is when there's no evidence of a primary tumor. And that can happen occasionally. Like occasionally I'll see a patient who has metastatic disease in their pleura with multiple little nodules in their pleura, but no definite primary tumor. And when you do a biopsy of the pleura, it looks like it's coming from a lung primary. So that would be a T0. A TIS and a T1MI. So these are two special categories that we see from time to time. And these are very low-grade tumors. And a TIS is carcinoma in situ, and a T1MI is minimally invasive adenocarcinoma. And on radiology, these are the tumors that are either ground glass in density or ground glass with a solid component. And remember that the solid component, when we do our pathology correlation, correlates with the invasive component. So T1MI means minimally invasive, and it means that the invasive part is less than or equal to 5 millimeters. TIS is carcinoma in situ, in which there's no invasive component on pathology. Okay? All right, let's move on to some questions. A patient with a 3-centimeter tumor has an enlarged gastrohepatic ligament lymph node. Which category does this affect? T, N, or M, or none? Okay, most people said node, and it's actually metastasis, so we'll get to that. I'm not sure if you can see the leaderboard. Can you see the leaderboard? Who is winning in this little competition? Let me show you. So Sarah is winning with 4,000 points. And Islam Zaki has 3,000, Rehab Ahmed, 3,000. I'm not sure if you can see that on your screen there. Okay, I have more questions, so there's still time. Let's go to the next question. So a patient with a right lung cancer has a supraclavicular node. Which category does this affect? So they have a right lung cancer, but a supraclavicular node. Is it part of node or is it part of MET? Okay, let's see. Okay, most people said node, which is correct. Okay, Sarah is still winning. Okay, let's talk about that. So the components of the N category are location. So a patient with an N0 is no enlarged nodes. Okay, a patient with N1 is ipsilateral peribronchial and hilar. N2 is ipsilateral mediastinal or subcarinal. And then N3 is contralateral mediastinum, hilum, or supraclavicular. Okay, I want to take about 5 minutes and just go over how to look at the lymph nodes, okay? And if you haven't already looked at this article, this article is the IASLC lung cancer staging project, and it goes over the categorization of lymph nodes. All right, so I highly recommend this article if you haven't already looked at it. I also have a YouTube video about this subject, so you could look at that too. But let me share this screen. New share. Okay, share that. And okay. All right, so can you see this screen here? Everybody see this? Okay. All right, so we start off with category 1, right? So category 1, or the first category for lymph nodes is supraclavicular when we're talking about chest lymph nodes. So supraclavicular goes from the cricoid cartilage at the top, which we don't have on this chest CT, to the clavicles and the sternum. So everything between that is 1, all right? And we can talk about this lymph node, for example, it would be 1R, and if we had lymph nodes over here, it'd be 1L. Okay, so 1 would be all supraclavicular lymph nodes. 2 is paratracheal, and specifically upper paratracheal. So the second section starts just below section 1, just below the supraclavicular region, and it extends on the right to the inferior aspect of the left innominate vein, and on the left to the top of the aortic arch. Now, for all intents and purposes, those are almost exactly the same level. So I use, for both right and left, I just use the aortic arch as my landmark. Okay, so lymph nodes to the right of the trachea are considered right paratracheal. Lymph nodes to the left are considered left paratracheal. Now, if we draw an imaginary line on the left side of the left border of the trachea, then lymph nodes that are to the right of that are considered right paratracheal, and lymph nodes to the left of that are considered left paratracheal. Okay, so if a lymph node is sitting immediately anterior to it, that's considered right paratracheal. All right, so most of the lymph nodes will be right paratracheal. There's few lymph nodes that are left paratracheal. All right, so that's 2R and 2L. Okay, the next would be 3. So 3 would be the prevascular region, and the prevascular region would be the lymph nodes that I consider the anterior mediastinum. So on the right, the posterior border is the SVC. So a lot of times there's a lymph node immediately anterior to the SVC here. And on the left, the border is the left common carotid artery. So things in the anterior mediastinum, these are considered 3A, prevascular nodes. There's also a 3P, which is retrotracheal lymph nodes. And these are lymph nodes just behind the trachea, going from the supraclavicular region to the carina. So this would be a retrotracheal lymph node, 3P. Okay. 4 is back to the paratracheal region, and we have right and left. So remember, we use the aortic arch, the top of the aortic arch, as our landmark. So here we have the arch vessels. When we go down to the arch, now we're already in the arch. So this is a 4R on the right side. And down here, this would be a 4L right here. Okay, and again, we're using our landmark of the left side of the trachea. So this is 4L and this is 4R. Now, there's also a lymph node right over here, lateral to the aortic arch, and this is considered a subaortic or AP window lymph node. And the landmark between left paratracheal and AP window is the ductus arteriosum. Okay, so the, or in an adult, obviously it would be the ligamentum arteriosum. So, okay, so this little structure right here is the ligamentum arteriosum. So medial to that would be left paratracheal. Lateral to that would be AP window or subaortic. Okay, so subaortic, by the way, is 5, level 5. Level 6 is para-aortic. So these are lymph nodes that are just lateral to the aortic arch or just anterior to the aortic arch. Level 7 is subcarinal region. So lymph nodes that are just underneath the carina are considered subcarinal. And when we get to the bifurcation of the bronchus intermedius, so we go to the right middle and lower lobe, that's the bottom of the subcarinal region. Below that, these lymph nodes are considered paraesophageal or in the pulmonary ligament. Okay, and then finally, hilar. So hilar nodes on the right are going to be nodes that are touching the main bronchi, right and left main stem bronchi, on the right below the azygous vein. Okay, so this is the azygous vein right here. Right here, that's the azygous vein. So below that, we get into hilar nodes. All right, so this is a right hilar node. Okay, this is a right hilar node. And on the left, the border is the main pulmonary artery. Okay, so this would be a left hilar node. This would be a left hilar node. And then there's lymph nodes beyond that, like interlobar, lobar, and segmental. And for the purposes of lung cancer staging, these are all considered to be N1 nodes. Okay, so whether a lymph node is here or all the way out here into the lobe, for lung cancer staging, those are all considered N1. Okay. Does anybody have any questions about those locations? Okay. That's something that if you just practice, you will get really good at. Okay. Let me check the chat 1 second. Okay. Yeah. So you just have to practice that, and you'll get very good at that. Let me go back to sharing my presentation here. All right. Oh yeah, so pretracheal. So lymph nodes that are just anterior to the pretracheal, you can describe them as pretracheal, but they're still considered right paratracheal. They're part of the right paratracheal group. All right. Okay, so N0 would be no lymph nodes, right? N1 would be ipsilateral, peribronchial, and hilar. So here we have a left lower lobe tumor, which I'm not showing you, and enlarged lymph nodes in the peribronchial and hilar region. Here's N2. So a subcarinal can be either right or left, right? So in this case, we have a tumor on the left side and a subcarinal lymph node. That's considered N2. If the tumor were on the right side, this same subcarinal lymph node is still considered N2. Okay, it's not considered the opposite side. And subcarinal is considered to be the same side as the tumor. And then N3 would be the other side of the mediastinum, contralateral mediastinum, the contralateral hilum, or supraclavicular nodes. Okay, so the question I asked about gastrohepatic ligament node, that is something that goes to the M category. That is that would be the same as having a lymph node in the inguinal region. That would be an M, a metastatic node rather than an N category. Okay. All right, moving on. A patient with a right lung cancer has an enlarging left lung nodule. What category does this affect? T, N, or M? You could probably guess what it is based on where we are in the lecture. We already talked about TNM, so this must be, okay, let's see. So it's actually M. So it's actually M, okay? So a patient, remember, so T3, a T3 tumor is when you have a nodule, a separate nodule in the same lobe as the primary, okay? That's T3. A T4 is you have a right upper lobe tumor and a right lower lobe nodule. That's T4. Now the M, if you have a nodule in the left, in the other lung, that's considered M. That's considered an M category change. All right. How about this? A patient with a right lung cancer has right pleural nodules. What category does this affect? Okay, let's see what everybody said. So most people said M, which is correct. Some people said T. And so if a tumor simply enlarges and goes through the visceral pleura, but there's no deposition of multiple nodules around the pleura, that is considered T. All right. Now, if a patient has nodules, discrete nodules in the pleura, but separate from the primary tumor, that's considered M. So in this question, this patient has multiple pleural nodules that would affect the M category, not the T category. Okay. All right, Sarah is still winning. 6,000 points. Let's continue. Okay, so, one more question. So a patient with a right lung cancer has a single metastatic subcutaneous nodule in the right chest wall, what is the M category? Okay, and most people said M1C, but the answer is M1B, and we'll talk about that in 1 second. All right, so now we're talking about the M, which is metastases. And M0 is no metastases. M1A is when you have intrathoracic metastases. And here we're talking about the thorax is contained by the rib cage. Okay, so if you have a subcutaneous nodule that's outside of the rib cage, that's considered either M1B, or if there are multiple, M1C. Okay. M1B is what we call oligometastatic disease, and it's one single lesion in a single organ. And M1C is multiple lesions, so 2 or more. All right. So in this case, this is no metastatic disease. M1A. So if a patient has pleural or pericardial nodules, that's M1A, or a contralateral lung metastasis. And I really like to use the sagittal images, because if you're just using the axial images, sometimes you can confuse the nodules along the pleura as being lung nodules rather than being pleural nodules. So in this case, this patient has multiple pleural nodules, which you can see really well on the sagittal images. And then if you look closely at the pericardium, if a patient has pericardial effusion, look for nodularity of the pericardium for metastases. Okay. M1B is a single lesion in a single organ. And so this patient had a right upper lobe tumor and a single lesion in the liver. And then M1C is multiple lesions. Okay, so this is a patient with skeletal metastases. Okay, so let's skip this question for a second and let's put it all together. So putting it all together, this is really the easy part of lung cancer staging, right? All you have to do is input what you saw in T, N, and M into a table like this one to figure it out. Now, since I'm a radiologist, I'm not going to talk too much about treatment, but I'm going to talk about a few specific parts of this table that I find interesting. The first thing is that these are the patients who are eligible for surgery. These are patients who don't have any mediastinal lymph nodes, only hilar nodes or no lymph nodes, and tumors less than 7 centimeters. So these patients are eligible for surgery if they, if they don't have other things that make them ineligible. These patients who have tumors less than 2 centimeters, segmentectomy is often preferred over lobectomy when the tumor is 2 centimeters or less and there's no lymph node metastases. These patients are non-surgical. So if a patient has a lymph node on the other side of the mediastinum, the hilum, or the supraclavicular region, that patient is not eligible for surgery. Or patient with metastatic disease, like a met in their liver, brain, then that is not surgical. Or patients with very large tumors and mediastinal lymph nodes. So those are all categories where it's pretty unequivocal that those are not surgical candidates. These are the patients who surgery is taken on a case-by-case basis. So these are T4 lesions, so greater than 7 centimeters. And usually these are not resectable except on select cases. And it's kind of rare for you to have a very large tumor, a 7-centimeter tumor, and not have any lymph nodes in the mediastinum. So there's very few patients who have a 7-centimeter tumor and only lymph nodes in the hilum. Usually they present with lymph nodes in the mediastinum. And then these patients, so the patients with ipsilateral mediastinal nodes, they can sometimes be considered for surgical resection, but usually it's after induction chemotherapy with or without radiation. Okay. And then a final category I want to touch on is these patients with oligometastatic disease. And for the purposes of TNM staging, it's one metastasis in a single organ. But for the purposes of treatment, patients are treated with as oligometastatic if they have less than 5 metastases. And the difference is if a patient is thought to have oligometastatic disease, then they can be treated more aggressively compared to a patient who has widespread metastatic disease, hopefully to increase the survival of that patient. Okay, and that is all I have for you. And let me just show you the leaderboard here. So here we go. Sarah won 6,000 points. Good job. Ala Ahmed, 4,000. Asma Ragab, 4,000. And Islam Zaki, 4,000. And Rehab Ahmed, 4,000. So you guys tied for second place. There were 4 people that tied for second place with 4,000 points. 2 people that tied for third place with 3,000 points. So good job. Good job, y'all. Does anybody have any questions? All right, awesome. Well, if you have any questions, feel free to, I'll share that paper, definitely. And if you have any questions, check out my YouTube channel and you can reach me through there. I have my email on there. Awesome. Well, thank you very much. It was a pleasure to talk to you guys.
Thank you.
Thank you so much.
دكتور طارق دياستي حضرتك معانا؟